Our next speaker really don't need any introduction, Dr. Mason. Besides being a strong advocate for patients, he's do tons of research with special interest in the very enlightening concept, the involvement of the virus in the etiology of PBC. So basically, you talk about PBC and why we get it. And just housekeeping. So you see the cards for questions, so you can write it down. But I want to make sure each speaker has enough time. So write the questions, and at the end, we collect them, and I can ask the speaker the questions. So I'll hand the mic to Dr. Mason.
Thank you, Minhee. So good morning, everyone. It's a real pleasure to be here. These are disclosures we have to show. And this is our current understanding of primary biliary cholangitis. This is an AI image generated by Midjourney. And I asked them, what is primary biliary cholangitis in the style of Hieronymus Bosch? And this is what it is. So the reason I'm showing this to you is not because it's odd, it's because it's just not definable. We have a rare disease that predominantly occurs in women, and it's difficult to study. And it's difficult to study because all autoimmune diseases are very difficult to study. Now, autoimmune diseases are called autoimmune diseases because you make some form of immune response to yourself, but it doesn't mean that immune response is causing the disease. So an autoimmune disease is, there are a bunch of diseases. They run in families, so it means there's some genes associated with it. And there's clearly some environmental influence, but sort of that's what we know from 40 years ago, and that's sort of what we know now, although we understand more of the genes. But it doesn't mean the autoimmunity is necessarily bad. So the anti-mitochondrial antibodies are great diagnostically because they help us diagnose the disease, but they don't necessarily cause the disease. And we know this because there are patients, possibly about 20%, that don't make those anti-mitochondrial antibodies, and therefore that can't be the cause, as it were. We also know that autoantibodies do some good, and there's a new science growing up now based on the treatment of cancers, where we use an immune stimulant to take... Ugh, it bit me. So we use immune stimulants to take the brakes off the immune system, and then the immune system fights the cancer. And a lot of those antibodies and T cells that fight cancer are cells that react to the self. And we actually see patients now who get the equivalent of hepatitis or colitis from their immune checkpoint inhibitor. And sometimes the patients that make the most immune response actually help clear the cancer. So an autoimmune response is not necessarily pathologic, and the immune system has to do its job around the body. So we look for clues about what's happening with PBC. We see it's a rare disease, but it's increasing worldwide, which we'll come on to. We know that female hormones with HRT supplements can make things worse. And we know that a younger age of first pregnancy predisposes more to PBC. So there's some idea that female hormones are involved. There are racial differences, I think, that JP will talk about in a bit. And the rising prevalence is a real sort of head scratcher. So someone came up with the idea with hygiene hypothesis. So the hygiene hypothesis is that now we're all washing our hands more and getting rid of these infections you see on the left, like rheumatic fever, measles and mumps, although measles is having a little bit of a comeback. Concurrent with this, we're seeing more autoimmune disease. So there is this argument that we're not educating our immune system properly with bugs. But there is an alternative explanation that whatever is in our communities is increasing worldwide, and that's why we're getting more type 1 diabetes and Crohn's disease and MS, etc. And this hygiene hypothesis it has some merit, because during COVID, we started seeing reports of this bad adenovirus causing acute, really severe acute liver disease in kids who had been at home for 3 or 4 years and had not been exposed to adenoviruses. And that may have been caused by, not being exposed to adenos and not having a good immune response to them. But we also saw an increase in PBC and in primary sclerosing cholangitis during COVID as well, and a bunch of rheumatic diseases like rheumatoid arthritis and lupus and systemic sclerosis. And this sort of jumped up, and I don't think there was enough time or of soap avoidance, as it were, for these diseases to occur because we weren't being exposed to pathogens. So another idea is that you get some virus, let's say Epstein-Barr virus is commonly found in patients with MS. And in this case here, we've got COVID that's triggering if not the development of these autoimmune diseases, it's triggering the presentation. So, for example, during COVID, the prevalence of type 1 diabetes went up in kids, and the incidence went up markedly. So it was being uncovered, as it were. So there's an idea that you have genes that don't cope so well with infections, and you get a virus that stimulates the affair and it sets you off on this journey. So that's one of the constructs. So why do I think PBC is an infectious disease? Well, non-related family members can get it. And when people move from India to Birmingham in the UK, the prevalence of disease went up in families from a low to a high incidence area. But I think one of the main things that tells me this is an infectious process, if you will, is you get 50%, up to 50% of patients following transplant can get recurrence, and that has differing severity, and most people will cope well with it following transplant. But the fact that it occurs when you've got a lot of immune suppression, that sort of indicates a recurrent disease process. And we find that when we use more potent immune suppression, the recurrence may recur earlier. So our practice now is to keep the immune suppression down as much as possible. Okay, so this is your first Slido question. If PBC is triggered by an infection, what is the risk of passing your disease on to your spouse partner? And I am voting nil. Okay, so what I can tell you is, as I said when we started, there's no correct answer here. I know 2 couples, husband and wife, who have PBC, and one of them got it much earlier than the other, and then the other got it. So I did a bit of a back of the envelope calculation, and so I'll probably go with 1 in 300 PBC couples, assuming that I know 600 PBC couples. So that's what I go with. I respect everyone's opinion, but the point I wanted to make is that if it is caused by an infection, you're not going around infecting people or anything like that. The epidemiology doesn't suggest that. But I can see none wins. So what causes PBC? Well, there's a ton of things associated with PBC. So we know that if you smoke, you should give up now. So the more cigarettes you smoke, the more likely your PBC is to be worse. It's a moderating factor. liver docs are very bad about alcohol, in as much as we know it needs a lot of alcohol to upset your liver, but sadly that's not true. With PBC, a small amount can be bad for you. So if you have cirrhosis, we say no drinking at all. And now the Canadian government has said you're only allowed 2 drinks a week anyway, so alcohol's done. The gut microbiome is very interesting because some of the animal models, which I'll come on to in a little bit, we work on, if you don't have bacteria in your gut, you don't get the disease. But there's clearly some form of modification of your bacteria, but that affects your general health, and we don't really know too much about that. Well, with genetics, we know that the genes, as I say, pass on the predisposition for the disease, but they don't actually cause the disease. And it looks like being an Indigenous American, which we'll hear about, actually increases your risk a lot. And I suspect that's probably a genetic thing. So this is an area where Gideon was very influential, well, he still is slightly, as a young geneticist, where he headed up with Kathy Siminovich the genetic study showing that it's mainly immune genes that predispose to disease. And when these studies came out, we thought, oh, we're going to find there's 1 or 2 bile duct genes involved, but that's not the case. So it looks like, if you look on the right, it's the family of autoimmune diseases, and some of those genes are abnormal in 5 or 6 different autoimmune diseases. And that tells us what we already know, that these autoimmune diseases sort of run in packs, in families. So the way I look at it, and I'm showing an example here with hepatitis C because it's easier to understand. If you have hepatitis C with one immune gene on the top left, you're more likely to get autoantibodies. So there's a gene that gives you, makes the anti-nuclear antibodies more apparent in your blood. And then if you've got the gene on the top right, you're more likely to get hepatitis C causing syndromes outside the liver, like cryoglobulinemia or other diseases. So the genes detect what we call the phenotype or the manifestation of the disease, but the infection dictates whether you get a disease. So here's our second question. If PBC is influenced by genes, what is the increased risk of my children developing PBC? So there's none, double, less than a 1 in 200 times, 5 times more likely, or a 30% chance. Well, there you go. So I think there's something called a sibling risk score, and it's a tenfold increase. So if your chance of getting PBC is 1 in 3,000, then you move to a 1 in 300 chance. But it's certainly not 5 times more likely or double or none. It's probably less than a 1 in 200 chance. So you go from 1 in 3,000 to maybe 1 in 300, something like that. But certainly the genetic predisposition doesn't cause too much more than that. So moving on to infections, there's xenobiotics. So Eric Gershon used to work on the idea that stuff in nail polish might stimulate an immune response. There's lots of bacteria as well that have been implicated, and I've been working on this beta retrovirus. But our visiting professor from Texas, way back when, pointed out that there was something called superantigen activity occurring in the liver of PBC patients. This is where some antigen, we don't know what it is, just turns on one of the subsets of your lymphocytes. And this is something that we've found as well when we look at our PBC patients, that these one set of lymphocytes is very much turned on. And this is something we see in mice. So more recently in mice, they've found antigen-activated autoimmune disease in three mouse models now. And these mouse models have evidence that they've got a viral superantigen that just turns on an immune response. And these mice respond to treatment, there we go, antiretroviral therapy, and the disease is transmissible if you pass on lymphocytes from one mouse to another. But this disease is not transmitted in the way you or I understand when you cough on someone in an elevator with measles. So this is interesting because we now know we can treat mice with antivirals, but that doesn't sort of translates to humans very well because we don't really have good antiviral treatments. So my lab has been working on making good diagnostics over the past few years. And on the left, you can see that we found the virus is in the DNA in biliary epithelial cells of more than 50% of PBC patients and some patients with autoimmune hepatitis. And on the right, we've made this a T-cell assay, which is like what we call a quantiferon assay. And we make this because the antibody responses to the virus aren't very good. So we've made a T-cell assay and we put virus proteins on T cells and we measure the amount of interferon that's produced. And about 50% of patients will have a positivity there. So we're hoping to get these assays out and then other people can either confirm or refute our data. But it's a very long-winded process and it takes a while. So in summary, this is a patient on the right who I just saw in clinic on Wednesday who's responded well to antiviral therapy. And we'd like to find more to complement these other new medications as well. And we hope to get our sort of diagnostics out. But I have to say, you have to treat this with a measure of skepticism until other groups confirm our data. And as I say, it takes a while. And in my case, a while's about 25 years, but it's been a good journey. Anyway, happy to discuss any of these studies. I'd like to thank my lab, and I'd also like to thank our industry partners who have helped support our studies in the Canadian Network of Autoimmune Liver Disease. And this is the way now we're progressing forward, trying to answer the more difficult questions with a large sample of patients in Canada, working with Gideon in Toronto. So with that, I'll thank you.